Hi, my name's Don Woodlock. I lead the healthcare business for InterSystems. And today I'm going to talk to you about successful use of healthy data, and especially some of the different machine learning and analytics use cases that we've been involved in with a few of our customers. So to start with, I like to talk about you before I talk about us. We've done a survey of 100 big health systems around the world for their top priorities related to analytics. And the number one priority was to create and share high quality data across the organization. By far the number one priority. So you want to create the data, you want to share it across your organization. However, there are barriers to that, significant barriers. And the most important is this data integration and interoperability. So pulling data out of these source systems, integrating it together is a barrier to you creating and sharing this data. So you might wonder, why doesn't it work like this? So you take data out of source systems like your electronic health records, and you just move it into an analytics technology from a big tech company, or move it into a machine learning stack. And it turns out a number of customers, of our customers, have tried this approach, but it doesn't really work that well. It seems like it would work on the surface, but the complexity of healthcare data means it really needs special treatment in the middle. And I'll give you one example. So you all probably have chief medical officers that want to answer a question like this: what is the percent of my high-risk cardiac patients that are on statins? Okay, so here's how this metric is defined by one standards body. And it's kind of complicated. You have a definition of the denominator, who are my high-risk cardiac patients. It has exclusions, it has exceptions in there, and one of the exceptions is patients who have active liver disease. So think, well, that's easy enough, I'll just exclude those patients. But the definition of active liver disease is not so simple either. In fact, in SNOMED, there are 7 pages of codes that just define active liver disease. So you have to get that definition right, and then you have to make that part of your high-risk cardiac definition, and then you have to make it part of your overall metric definition. So it gets very complicated very quickly, even things that sound like they would be easy. So the way we see it is you need something in the middle that really cleans and makes your data healthy and normalizes it and integrates it together. So that's what we refer to as our health share data fabric. And once you do that, then all your users of that data, be it machine learning, be it analytics folks, administrators, researchers, downstream systems, can really have that same definition, in my example, of high-risk cardiac patients, or liver disease patients, or high-risk pregnancies, or those kinds of things. So with that, I'll just take a few minutes also to talk about some machine learning projects that we've done with some of our customers based on this cleaned up data. The first is with a customer named Northwell Health. They're a 23 hospital system in the New York area in the States. And what they wanted to do was to better predict the length of stay of patients that were currently in their hospital. And the way they looked at it is every day that the patient stayed beyond a DRG-based length of stay that their payer, the main payer, CMS, was paying them on, would be money lost to the hospital. So what Northwell wanted to do is work with us on a project to better predict the length of stay. And the scenario is that they were paid based on a length of stay based on the DRG. And every day the patient stayed beyond that prediction was money lost. They weren't paid any more money for that stay. So they wanted to better accurately predict how long the patient was going to be in the hospital. And in particular, they wanted to predict the patients that would be discharged that day and incorporate that into a discharge readiness app. Now, before we do machine learning, we always like to baseline. And if you just used CMS, which is their main payer, the DRG-based prediction, it's only 35% accurate as to who is going to leave the hospital that day. So it's not that useful. We built a machine learning model, and so far we've got it up to 84% accurate. It was built on 4 years of their inpatient data, about 1 billion rows of data across the system. About 22 billion raw data points are used in the training process, and got up to that very high accuracy. We also built some explainability in the model to help the overall folks understand what drives length of stay overall, and then on an individual patient case, why the model was predicting what it was predicting for that patient. Another example is work we did with Bay State Health around predicting appointment no-shows. And what I'm showing here is the global explainability for that one. And you can see that how long ago the appointment was booked, whether there's a telephone number on the appointment type, are main factors in this model. But you can also see some social determinants of health, like the number of people in the household, whether they have access to transportation, the stress level, those kinds of things. And we all know social determinants really drives clinical outcomes, but it also drives administrative outcomes, frankly. And then we had local explainability as well. You can see, for instance, the very first row, this patient has an 86% chance of not showing up for the appointment, and those are some of the explanations why. But you can use this to reach out to the patient or double book the appointment slot or those kinds of use cases. And then the third use case I'll talk about is a general model around predicting the probability of a variety of events happening for a patient in the next 12 months. So one was whether the patient will visit an emergency room or the patient will get diabetes. And they put this display in our clinical viewer. You can see the example there. So the clinicians in the ED can have a different kind of conversation with the patient in light of these risks. Maybe they can talk to the patient about urgent care centers or their diet and exercise or those kinds of things, knowing the risk of the patient. But in addition to the patient level, they also use it for cohort management. So you can build a list of patients that have a 80% chance or more of developing diabetes in the next year. And you could reach out to those patients or enroll them in programs or decide where to build your next clinic or those kinds of things. So you can really use AI both on an individual patient care level, but also on an overall population management level and cohort management level. So that's it. I just wanted to give you a couple examples of both healthy data and some of the cool things you can do with healthy data using technology like ours. Thank you very much.